So I am here to present a partial veneer case. It is a very difficult case, and it is very important that doctors should be coordinated with the lab, and the cementation was also very tough, and I think Dr. Radhika is here and she did it well. So I'll go through the cases. The patient came to us, and I'll just show the patient. We are introduction to the new era of digital dentistry. So this is this is the partial veneer case. So this is the pre-operative image of the patient. So patient is having a diastema, and she wanted to go. She was worried, okay, how it will be and why should I go. So we showed her some digital designing, and she was how the parameters will be, and she was quite convinced. So, but I was not convinced in going for a full prep veneers. So I told doctor that let us try something different. So we did a minimal prep. You can see the notch. It's a 0.1 mm notch was created on the 3, 1, 1 and 2, 1. And this is the model. So these are the veneers. We were not able to click much of the pictures quite good because we have delivered this case within 2.5 hours. So the thickness of GCAM was 0.01 mm. So now you can think how it might be so difficult for a technician to handle it and so difficult for a dentist to lute it in patient's mouth. And now they need to be sandblasted. So all the cementation protocols were done by VarioLink, and Dr. Ramesh guided me throughout the case, and no one can make out till that the partial veneers are placed in her mouth. Only 3 partial veneers are placed, and even patient was not able to recognize that she is having such a drastic change. So if anyone wants to know about it or ask the questions, please. So we followed the lithium disilicate protocols for this. It is still intact. It's a new material for us also. So even we are trying a lot of, till date we have cemented 70 units of GCAM, and none of them have came out yet. So from first unit till the 71st, we have used VarioLink. So we have not missed any of the cementation protocol till date, but let's see. I'm hoping, and most of our prosthetic in the posterior region, if it is a single unit, we have gone till 0.02 mm in the posterior. So if doctor is having a vital case and if he feels that zirconia is not an option and patient don't want a metal, I would recommend to go for a GCAM. And we have loaded more than 30 crowns on 0.4 mm and still they are intact without any crack. But in the same condition, if I have loaded zirconia, I am 200% sure it would have cracked down within 2 months.
From my point of view, 0.2 is very less. I don't think you should go with that.
No, it depends upon the conditions. So we are trying up with the material how we can use it. See, it's definitely.
Don't go with that minimum thickness or like anything you can do it and think about it so long.
No,
because
I'm
for
not thinking
3 months and
about
6 months is like ideally every material should have some protocol and you should follow that protocol. Don't take your it can be survive or not like
No,
that.
it is not about the survival. Kush sir has given me the material for a research purpose. So I am trying to exceed the level of a protocol because we stay in India. And as everyone knows, how cast we get in lab, every technician knows what is the condition he is facing. If I call doctor and say, sir, I need 1.5 mm clearance, and I call him, sir 1.5 नहीं है, सिर्फ 0.5 है. नहीं 1.5 ही है, मैंने 1.5 का ही बर से कटिंग किया है. So when I say 0.5, doctor has called me and said, sir, I have did 1.5 mm clearance, but on model I am only seeing 0.5 mm clearance. mostly why my crowns are intact, because all the occlusal corrections have been done, and if you have to exceed the protocol, you need to be very much firm about the occlusal forces. The lateral protrusion movements need to be checked, which cannot be properly checked on the models also. I try 80% to correct it on the model, but 20% are the doctor efforts that doctor takes, and the crowns are intact. If doctor won't take that 20% effort, that crown will break down. I am 100% sure about it.